In part one of this series, I made you a promise. I told you that part two was going to make some of you uncomfortable, and I meant it. But I want to be honest with you before we dive in, because I've thought a lot about how to open this episode. The uncomfortable truth isn't that you've been doing everything wrong. It's actually almost the opposite. Most of the language patterns we're going to talk about today were taught to us. We learned them from our supervisors, from instructors, from the culture of our profession. We've been repeating them in good faith with genuine intentions because nobody ever told us to question them. So, this episode isn't an indictment, it's an invitation. An invitation to look at something most of us in the MSK world are doing every single day without realizing it, and start doing it differently. Let's get into it. Hey there, I'm Jamie Johnston, and you're stepping into a new era of thriving as a massage therapist. We're embracing who you are, pursuing what you love, and confidently shaping your practice. We'll challenge industry norms, spark change, and discuss what truly matters. Things like mental health, evidence-based practice, and some topics we've long avoided. Let's create better outcomes for our patients and happier, more fulfilling practices together. Welcome to the New Generation Massage Therapist Podcast. Welcome back. I'm Jamie Johnston, and this is part two of our three-part series, Are We Mental Health Professionals? If you haven't listened to part one yet, I'd encourage you to go back and start there. We laid some important groundwork, the research on massage therapy and mental health, the concept of the therapeutic alliance, and why understanding your patient's mindset changes everything about how you approach a session. Today, we're building on that foundation, and we're going to spend most of this episode on a single concept that I think is one of the most underappreciated ideas in all of healthcare, and that's the nocebo effect. Let me start with two words that come from the same Latin root. The first is nociception. You might have heard of this one. It comes from the Latin nocere, to harm, and refers to the nervous system's response to stimuli that are potentially harmful. It's the physiological process that leads to the perception of pain. Now, we didn't learn a whole lot about nociception in school, but it's still really important for us to know. And the second word is nocebo. And this one, most of us weren't taught. Nocebo translates literally from the Latin as I will harm. In medicine, the nocebo effect refers to adverse, harmful, or unpleasant effects experienced by a patient, not because of anything physically harmful that was done to them, but because of negative expectations. But before we go there, I want to talk about its counterpart, because I think understanding both sides of this coin is what makes this concept so powerful. Placebo comes from the Latin for I will please. And the placebo effect, positive expectations producing positive outcomes, is one of the most well-documented phenomena in all of medicine. We talk about it all the time in healthcare, usually in a slightly dismissive way, saying things like, it's just the placebo effect. But here's the thing. The placebo effect isn't a trick. It isn't a sign that nothing real happened. It is a genuine, measurable neurological response, and the research on how it works has profound implications for what we do as massage therapists. There are four specific ways that placebo analgesia, placebo-driven pain relief, is increased. And when I walk you through these, I want you to think about your own practice, because I think you'll recognize all of them. The first is when the patient believes they have received an effective treatment. Not just a reasonable treatment, an effective one. The belief itself is doing clinical work, which means the confidence you project, the way you explain what you're doing and why, and the clarity of your treatment rationale are not just communication skills. They're part of the treatment. The second is when a patient is conditioned to expect a placebo intervention to be effective. And here's the one that should really make you think. Just walking into your office can influence this. The environment you create, the way your clinic feels, the impressions your space makes before you've said a single word, all of it is conditioning your patient's nervous system to expect a positive outcome, or not. The third is when a patient is conditioned with an effective treatment and then given a placebo treatment. In other words, a prior positive clinical experience carries forward. Every time a patient leaves your room feeling better, you're building a conditioned response that makes the next treatment more effective before it even begins. And the fourth is when a prior successful experience exists, or when the environment includes other people benefiting from the treatment. So think about your waiting room. Think about the patient who walks past the person who just finished their session. That person walking out relaxed, moving better, smiling. That interaction is actually doing clinical work. Your waiting room isn't just a neutral space. So, what does all of this tell us? It tells us that by using positive framing, an enthusiastic attitude, and genuine confidence in what we're doing, we increase the perceived value of the person's experience, and we increase the placebo effect for a better, more positive outcome. Your belief in what you're doing is therapeutic. Your confidence is clinical. Your environment is part of the treatment. And now, here's the other side of the coin. If positive expectations produce positive outcomes, and the evidence says that they absolutely do, then we have to accept that the reverse is equally true. Negative expectations produce negative outcomes. And we're triggering that in our patients every single day. This is the nocebo effect. And once you understand it, you'll never hear your own language the same way again. So, what does nocebic language actually sound like in a treatment room? I want you to listen to these not with judgment, but with recognition. Because most of us have said some version of these things. I know I have, and I've done it repeatedly. And when we said them, we meant well. We were being thorough, being transparent, doing what we were trained to do. But knowing what we know now about the nocebo effect, that negative expectations produce real, measurable outcomes, we have to look at this language differently. Let's start with some of the most common phrases in our profession and what we can say instead. So, for example, something like chronic degenerative changes. This one comes up constantly, and it's often from imaging reports that patients bring in, sometimes from our own clinical explanations. What it actually means, in most cases, is normal age-related change. Because here's the thing. If we scanned everyone in this profession over the age of 40, the majority would show some degree of what radiologists call degenerative change. It's a normal part of aging. Calling it degeneration tells the patient that their body's deteriorating. Calling it normal age-related change tells them their body is doing exactly what bodies do. Let's look at another one. Wear and tear. Same category, same problem, same solution. Normal age-related change. How about bone on bone? This one genuinely frightens people. They hear it and imagine two grinding surfaces destroying each other with every movement, that every step, every reach, every twist is causing catastrophic damage. And here's a real world example of why the label doesn't tell the whole story. If you're a hockey fan like me, you probably remember Steve Yzerman leading the Detroit Red Wings to their Stanley Cup runs in the late 90s. During that time, I heard repeatedly that his knee was basically bone on bone. And yet there he was, playing at the highest level of professional hockey, winning championships. Now, did he have exceptional medical support? Absolutely. Was there management happening behind the scenes? No question. But the point stands, a label that sounds like it should mean you can't function didn't stop one of the greatest players in the history of the game from performing at an elite level. So, a more accurate and far less threatening description of bone on bone is narrowing or tightening of the joint space. It's honest, it's specific, and it doesn't send the patient's nervous system into threat mode. How about instability? When a patient hears that a part of their body is unstable, they immediately become afraid to move it. They guard it, protect it, avoid loading it, all of which typically makes things worse. What we usually mean when we say instability is that an area needs some more strengthening and control. That framing gives the patient something to move toward rather than something to be afraid of. And how about lordosis? Now, this one's a little bit personal to me because when I was a kid, doctors and that would always say that I had a sway back. And this one's really interesting because it's technically just an anatomical term for the normal curve in your lower back when we say lordosis. But when a patient hears a clinician say, you've got a lordosis or a hyperlordosis or a sway back, especially with any kind of concerned tone, they hear something is wrong with the shape of my spine. Call it what it is, the normal curve in your back. How about negative test results? I know this one feels counterintuitive. Negative sounds bad. But in clinical language, negative means we didn't find what we were looking for. So instead of telling a patient their test was negative, try everything appears normal. Same information, completely different emotional landing. Now, each of these alternative framings has something in common. They're not less honest, they're not sugarcoating. They're more accurate descriptions of what is actually happening, delivered in language that doesn't activate threat and fear in the person receiving them. That's the key distinction. This isn't about being optimistic at the expense of truth. It's about recognizing that how we say something is as clinically significant as what we say. And this matters not just for the language we use ourselves, but for the language our patients arrive with. Because just this past weekend, I was part of an online discussion where a massage therapist had asked a question that I think a lot of us have wrestled with. They asked, what's the best way to educate a patient who is dead set on the idea that their rib has gone out and is asking you to put it back in? And it sparked a little bit of a lively debate, which told me two things. First, that this is happening in treatment rooms everywhere right now. And second, that a lot of us aren't sure how to handle it. So let me tell you what I do. When a patient comes in convinced that their rib has gone out, I don't dismiss what they're feeling. Their pain is real, their discomfort is real, but what I gently question is the explanation they've been given for it. I'll often pull out an anatomy reference and show them the structure of the thoracic spine and the rib cage. I'll point out the costovertebral joints, the ligaments at the head of the rib, the sheer density of the connective tissue holding those structures together. And I'll say something like, look at how strong this is. These ligaments are incredibly robust. The idea that a rib has gone out, the way people imagine it, well, there actually isn't much evidence to support that. What's more likely, and what the more recent research suggests, is that what you're experiencing is closer to a rib sprain. The joint's been irritated, the surrounding tissues are sensitized, and that's producing real pain. But it's not a structural dislocation. And I love how my colleague physiotherapist Bahram Jam put it in one of his writings on this exact topic. He said, and I'm paraphrasing, that rib subluxations have been described, identified, and treated for over 100 years. Yet there's still a lack of any scientific evidence supporting the existence of the phenomenon. And his conclusion was that as clinicians, we should embrace the evidence and not instill fear into patients by describing their ribs as having gone out or subluxed, but instead, describe the same condition as ribs that have simply been sprained. Because that, he argued, is likely closer to the truth, far more reassuring to the patient, and inevitably better for their recovery. And in my experience, when you explain it that way, calmly, confidently, with the anatomy right there in front of them, patients almost never push back. They're not attached to the explanation. They're attached to feeling better and feeling understood. Give them a better explanation, and most of the time, they'll take it. Now, I want to be really careful about how I frame this next part, because the language patients arrive with rarely come out of nowhere. It came from somewhere, often from another practitioner. And that practitioner, in almost every case, was not trying to harm their patient. They were doing what they were trained to do, using the language they were taught, operating from the best information they had at the time. I always think of these as well-intended practitioners, because that's exactly what they are. So when a patient comes in carrying nocebic language from a previous clinical encounter, saying something like, my other therapist said my spine is really vulnerable, or my chiropractor told me my pelvis is rotated out. My job is not to undermine that practitioner. It's not to make the patient feel like they've been misled or that the care they received was wrong. That would fracture their trust in healthcare broadly. and it would put me in a position of judging a colleague I've never met based on a secondhand account. So what I do instead is acknowledge and redirect. Something like, well, it's great that you've been getting some support for this. That terminology, the rib being out or the pelvis being rotated, that's actually some older language that's been used in our profession for a long time. What the more recent research is showing us is a slightly different picture, and then I offer the updated framing. In doing that, I'm not saying the other practitioner was wrong or harmful. I'm simply positioning the conversation as an evolution of understanding, which is what it is. And here's why this matters beyond just being tactful. When patients hold on to structural explanations for their pain, when they believe that rib is out, their pelvis is rotated, or their spine is crumbling, they catastrophize. They become afraid of movement. They seek repeated treatment not to get better, but to be put back together. They develop a kind of structural dependency that doesn't serve their recovery. But gently pulling them forward to a more accurate, more empowering explanation isn't just good communication. It's clinical intervention. It changes outcomes. So let me give you the mechanism, because I think understanding why this happens, not just that it happens, is actually what changes how you practice. Your patient's brain is a prediction machine. This is a well-established concept in neuroscience. The brain is constantly taking in information from the environment, from the body, from the words and tone and facial expressions of the people around it, and using all of that to build a model of what is happening and what's about to happen. Pain is part of that predictive process. Pain isn't just a signal from damaged tissue. Pain is the brain's interpretation of threat. And one of the most powerful inputs into that threat assessment is language. When you tell a patient, oh, this muscle's completely locked up, or there's a lot of damage in here, you haven't just described a physical finding. You've introduced ambiguity and fear into their predictive model. And ambiguous or fear-evoking language does something very specific. It increases anticipatory anxiety and pain catastrophizing. The patient's nervous system starts scanning for danger. It starts bracing. And their perception of threat, and therefore their perception of pain, increases accordingly. Here's what makes this particularly significant for us as practitioners. We're not just describing what we find. We're actively conditioning our patients through our explanatory models. Every time we use language that frames the body as damaged, fragile, or deteriorating, we're conditioning that patient to expect pain and inevitable physical decline. And just as we saw with the placebo effect, that conditioned expectation produces real outcomes. This is the practitioner's power, and it works in both directions. Used well, our explanatory models are powerful psychological tools that build confidence, reduce threat, and create the conditions for recovery. Used carelessly, those same models trigger fear of movement, psychological distress, and a sensitized nervous system that is primed to experience more pain, not less. So let me give you a clinical example of how early this conditioning can take hold. Years ago, when I was working with Hockey Canada, a young athlete, she was around 17 years old, got on my table for the first time. As I started working, she looked back at me and asked, "Do I feel tight?" I said, "Honestly, I have no idea. I've never treated you before, so I wouldn't have any reference point for what's typical for you." And she seemed almost surprised by that. She told me that her therapist at home always told her how tight she felt at the start of every session. So then I asked her a different question. I said, "Do you think you feel tight? Right now, lying there, do you have a sense of tightness in your lower back?" She thought about it for a moment and said, "No, not really." "Well," I said, "you're probably not tight then. What's far more important is how you feel, not what I say that I'm feeling when I'm treating you." And that exchange has stayed with me, because here was a 17-year-old athlete who had been walking around believing her body was chronically tight. Not because she felt it, not because it was limiting her performance, but because someone in a clinical role told her that she was, repeatedly, session after session. That's conditioning. That's a belief about her own body that someone else instilled in her. And left unchallenged, it's the kind of belief she would have carried into every treatment room for the rest of her career. So this is what we mean when we say our explanatory models are powerful psychological tools. We're not just describing what we find, we're shaping how patients understand and experience their own bodies. And that responsibility doesn't begin when things go wrong. It begins the moment they get on our table. And the research on this is remarkably consistent. Studies on surgical patients show that even the language used during preoperative briefings changes pain outcomes post-surgery. Studies on pain patients show that catastrophizing language from clinicians, language that emphasizes damage, fragility, and threat, is one of the strongest predictors of poor outcomes, chronic pain, and long-term disability. We have a responsibility to understand this, because if we know that the language we use is actively shaping our patient's central nervous system's perception of threat, that our words are influencing their anticipatory anxiety, their pain catastrophizing, and ultimately their outcomes, then choosing that language carefully isn't optional. It's part of the clinical work. And that sits pretty close to a principle that most of us hold dear. First, do no harm. So, what do we do instead? The answer isn't to lie to your patient. It isn't to pretend nothing is wrong when something is. It isn't to be relentlessly optimistic in a way that feels fake and undermines their trust in you. The answer is clinical reassurance. And it's one of the most powerful therapeutic tools available to us. Clinical reassurance means providing accurate, honest information in a way that is contextualized, framed to reduce threat, and oriented toward recovery and capability rather than damage and fragility. So let me give you some examples of, how this works in practice. One of the most common things patients come in believing is that their posture is causing their pain. And for a long time, that's what we told them too. But the research is telling us a different story, one that shows there actually isn't much of a correlation between posture and pain. So when a patient comes in attributing their lower back pain to their posture, rather than reinforcing that belief, we'll ask them a few questions. How long have you been experiencing this pain? When did it actually start? And before it started, do you think your posture was really any different than it is now? Most of the time, they'll think about it and say, no, not really. And that's the opening, because if their posture hasn't changed significantly and the pain is new, then posture probably isn't the culprit. We can confidently start looking at other options together. If it's somebody that I've been seeing for a while, I might approach it slightly differently. I might say, your posture doesn't look any different than the last time I saw you, and you weren't dealing with this pain then. Same logic, just using our shared clinical history as the reference point rather than their own memory. Either way, I always try to close that conversation the same way. Because while posture as fixed state isn't the problem, movement absolutely matters. And the reframe that I find most useful, the one that seems to stick with people, is this, and I've learned this from other people, is to just say, the most important posture is your next one. Just keep moving. Whether that's sitting, standing, getting down on the floor with your kids, just make sure you're getting into the next position. That gives them something actionable, something empowering. Instead of walking out afraid of how they're sitting, they walk out understanding that their body is built to move and that movement itself is the medicine. Now, let me give you another example, one that I think illustrates just how consequential our language choices can be. Because this isn't just about patients feeling a bit better or worse after a session. Sometimes the words we use, or the words another well intended practitioner uses, shape the entire trajectory of someone's life. I had a patient come to see me who had been through a frozen shoulder surgery. She had worked as a hairdresser for her whole career. It was her livelihood, it was her identity, and she loved being a hairdresser. But following the surgery, her physiotherapist and her surgeon told her that if she went back to hairdressing, the surgery she just had would pale in comparison to the one that she would need next. So she stopped. She quit the career that she loved and took a government job sitting at a desk that she hated because two trusted clinical voices had told her that using her shoulder the way her work required would destroy it. When she came in to see me, she couldn't lift her arm past 90 degrees. In the first session, we got it up to about 120, and over the next few sessions, we got it into full range at 180 degrees. And at some point during that process, she asked me, "Do you think I could try cutting my husband's hair?" I said, "Go for it." And then I gave her one very specific piece of clinical reassurance before she left. I said, "Just keep in mind that this is something you haven't done for a long time, so you'll probably be sore afterwards. But I want you to remember that soreness isn't your frozen shoulder coming back. It's not a sign that something's wrong. It's just your body responding to an activity that it hasn't done in a while. Like starting any new exercise, there's going to be some stiffness and discomfort while you rebuild up that tolerance. That's normal. That's expected. And it will pass." That reframe matters enormously because without it, the first time she felt discomfort after cutting her husband's hair, she would have catastrophized. She would have assumed the worst. She would have stopped again, not because her shoulder couldn't handle it, but because nobody had prepared her nervous system for what normal post activity soreness feels like after a long period of disuse. Clinical reassurance isn't just about what you say during the session, it's about preparing your patient for what comes next so they have a framework for interpreting those sensations accurately rather than defaulting to fear. Let me give you a couple more examples worth having in your toolkit. Instead of saying something like, "Well, you've got a lot of damage here," try, "There's some sensitivity in the area, which makes sense given what you've been dealing with." Sensitivity doesn't always mean structural damage. Often it means the nervous system has become a little overprotective, and that's actually something we can change. Instead of, "If you keep doing that, this is going to get a lot worse," try, "Let's talk about some ways we can load this differently so your body can start to build tolerance and confidence in that movement again." Do you hear the difference? The first set of statements tells the patient their body is broken and working against them. The second set tells them that their body is intelligent, that it's responding to a situation, and that there's a path forward. Both can be honest descriptions of what's happening, but only one of them creates the conditions for recovery. This is what I mean when I say the words we choose are clinical decisions, not just communication preferences. Clinical decisions with real, measurable outcomes. Now, I want to talk about something that trips a lot of practitioners up, and it's something I'd call the reassurance trap. Because there's a big difference between clinical reassurance and false reassurance. And if we're not careful, in our effort to avoid nocebic language, we can swing too far in the other direction and end up being dishonest with our patients in a different way. False reassurance sounds like this: "Don't worry about it. You'll be fine. There's nothing wrong with you. Just ignore it and it'll go away." These statements might kind of feel kind in the moment, and it's not ones that I've used in the past, but I'm sure I've used some version of that. But they invalidate the patient's experience. They dismiss legitimate concerns, and they erode trust because often the patient knows something's wrong, and being told otherwise makes them feel unheard. But here's where it gets nuanced, and this is important. Clinical reassurance doesn't mean reassuring patients around whatever they happen to believe. We only reassure what is true. Let me give you a common example. We'll go back to that patient who is absolutely convinced that their rib is out. It's a belief that gets passed around a lot, and patients arrive with it regularly. If we simply validate that belief to make them feel better, and we say, "Well, don't worry, we'll sort that out," we haven't delivered clinical reassurance. We've delivered false reassurance built on an inaccurate premise. And in doing so, we've potentially missed what's actually going on clinically. Clinical reassurance means validating the patient's experience, their pain, their fear, their frustration, while educating them accurately about what is actually happening. Those are two different things, and both matter. Which brings me to a framework that I think is worth having. Clinical guidelines actually recommend reassurance as a first line intervention, not just a communication nicety, but an active clinical tool for reducing fear, worry, and doubt. And it works on two levels. The first is affective reassurance, providing emotional comfort by showing genuine empathy and validating the patient's experience. This is the human part. It's making sure the patient feels heard before you do anything else. It sounds like, I can hear that you've been dealing with this for a while and that it's really affecting you. That makes complete sense, and I'm glad you came in. The second is cognitive reassurance, changing negative thought patterns by educating the patient on how pain actually works, helping them understand that pain doesn't equal severe damage, that sensitivity in a region doesn't mean that region is broken, that their nervous system can become overprotective without there being a structural catastrophe underneath it. When you combine those two things, empathy and education, affective and cognitive reassurance working together, you're doing something that goes well beyond manual therapy. You're actively treating anxiety. You're reducing pain catastrophizing. You're changing the neurological conditions under which that patient is experiencing their pain. Are we mental health professionals? No. But clinical reassurance delivered well is a legitimate and highly effective psychological intervention, and it's available to every one of us in every session. Now, I want to give this framework the full attention it deserves because there's a lot more to unpack around how affective and cognitive reassurance actually work in practice, what they sound like in real clinical conversations, and how you sequence them effectively. So I'm going to dedicate a full episode to that. But if we rush it here, we won't do it justice. What I want you to take from this episode is the foundation. Understand that clinical reassurance is a clinical tool. Understand that it only works when it's grounded in truth. And understand that the goal is never to make patients feel good about a false belief. It's to help them understand their real situation in a way that reduces threat and creates the conditions for recovery. Now, I want to zoom out for a minute before we close, because what we've been talking about today isn't just choosing nicer words. It isn't about being soft or avoiding difficult conversations with patients. It's about recognizing that the therapeutic relationship itself is a clinical instrument, and that how we use it determines outcomes in ways that go far beyond our technical skills. The research on therapeutic alliance is compelling enough that it deserves its own conversation. And honestly, it's going to get one because there's far too much there to do it justice in this episode. But the short version is this: across virtually every healthcare discipline, the quality of the relationship between practitioner and patient is one of the strongest predictors of outcomes, stronger in many cases than the specific technique being used. And that doesn't mean that techniques don't matter. It does. But it means that if you're technically excellent and relationally careless, if your hands are skilled, but your words are creating fear and helplessness, you're leaving a significant amount of your therapeutic potential on the table. And the reverse is also true. A practitioner who is genuinely good at building trust, reducing threat, and helping patients feel safe and capable in their own bodies, that practitioner is doing something that no amount of technical skill can fully compensate for if it's absent. My mom used to say it to my brother and I when we were kids. Usually she'd hear us yelling at each other, trying to get a point across, just fighting with each other. And she'd go, "It's not what you say, it's how you say it." I've carried that with me. And I think it applies here more than almost anywhere else I can think of. Language is not separate from treatment. It is treatment. And how we use it, the words we choose, the tone we take, the beliefs we reinforce or gently challenge, that is clinical work. It always has been. That's a wrap on part 2 of this series. And if you haven't listened to part 1 yet, go back and start there. This conversation builds on that foundation, and the next part will build on this one. So you'll get the most out of that if you take them in order. If this episode made you think differently about the way you communicate with your patients, even just one conversation, one word choice, one reframe, then it's done its job. And honestly, that's how this stuff works. You don't overhaul everything overnight. You just start noticing, and then you start shifting. And over time, those shifts compound into something that genuinely changes outcomes for the people in your care. If you want to go deeper on the communication side of things, particularly around mental health and psychological health, I do have a sign up list, and I'll put the link in the show notes. It's one of the most practical things you can do to complement what we've been talking about in this series, and I think you'll find it genuinely useful. And if you're part of the community, you'll be seeing this content here too. So keep an eye out for that. If you're finding value in the New Generation Massage Therapist podcast, the best thing you can do is follow the show wherever you're listening. And if you have 2 minutes, leave a review. It makes a real difference in helping other practitioners find this content. And this is exactly the kind of conversations our profession needs to be having more of. I'll see you in part 3.